maybe quickly review the history of the patient that Dr. Sham is going to operate for us. She is a 53 years old lady presented with recurrent right side foul-smelling discharge. And she has had repeated courses of antibiotics by general practitioners as well as in our unit. And nasal endoscopy saw actually a mass coming from, maybe hanging down from the middle meatus. And the rest of the examination is essentially normal. And I would like to show you two cuts of the CT, but Dr. Sham is going to show you the more detail. As you can see, this patient has unilateral disease. The anterior ethmoid is opacified. The frontal recess is clear. The other side is normal. And a cut further back, you can see the maxillary sinus on the right side is completely obstructed by a mass in the which is also essentially fill up the middle meatus. And if you look more carefully inside the sinus, there's heterogeneity of the tissue contents. Perhaps this can be a case of fungal sinusitis. Maybe without further ado, I would pass the presentation to Dr. Sham now.
Okay.
Okay, Sham, we are with you.
Okay, thank you, John. So you have heard from the history, this lady had a long history of right nasal obstruction and bleeding. From the CT scan, I would like to show you some important findings. Do you see the CT of the patient?
Yes, we see very well.
Okay, we start from the first cut. You can see the frontal sinus very well. Can you have a close-up view? Okay, the frontal sinus, well pneumatized. Okay, we start seeing some anterior ethmoidal disease here, and at the back, here, anterior ethmoidal disease. Further back, we see the bulla looks quite all right. And here we see the right maxillary sinus is all opaque with some calcification inside. Okay, it's bulging into the middle meatus. Okay, further back, some calcification. The rest of the other sinuses are all right. So this is basically a limited disease in the maxillary sinus. So what I would plan to do now is to go inside, biopsy some of these specimens for culture and section, and then we'll try to take all these out. The approach that I would take may be, first of all, through the middle meatus. If I can't take it all out, inferior meatus by meatal approach. If still I have problem, I may have to go through the canine fossa, do a sinoscopy through it. Okay, the nasal septum is deviated, as you can see here. We have a sharp spur here that I may have to take down. Okay, here, the sharp spur. Otherwise, it's relatively straight. Okay. Do you have the endoscopic view now? Yes. 較光少少啊，唔該。俾一塞下。How's the picture now?
Picture is very good actually.
Okay. So we started by looking at some of the anatomy here. The septum is quite all right here until in the mid-nasal area we start seeing a spur here that I may have to take down. Okay, further back, middle turbinate, uncinate process on the lateral wall, and we start seeing the fungus material protruding into the nasal cavity. Okay, so I would like to take down this spur before we start. 俾個 injection.
Sham, would you just like to tell us how you have prepared the nose before we have joined you?
I've put in ribbon gauze, soaked in 5% cocaine with 1 in 10,000 adrenaline, 6 mils altogether into 6 ribbon gauzes. So we packed the nose for about 15 minutes already. 俾個 packing force 先。So I deliberately left one ribbon gauze in the inferior meatus in case we may have to do a bimeatal approach. So I would inject a little bit of silocaine. Okay. Further back. Okay. Suction elevator.
Sham, you mentioned you may need to do a septoplasty, but will that be suffice if you just take down that little spur rather than a formal septoplasty?
Yeah, it would not be a formal septoplasty, but I will just take down this small spur. This is in the way. So I would like to elevate the mucosa and strip it down. Cái直嘅 forceps 細嘅有冇 Tilly forceps pack 鼻嗰隻，呢就有啲細嘅直嘅 forceps 好唔好啊？好，俾個 free 嘅先我。俾翻 suction free 嘅先，好，俾個直嘅細鉗，冇，係 ，OK， 再俾個 suction free 啊我。
And for the audience here, I think if at any time anybody has any question to raise, if you just put up your hand, we will have a microphone that can circulate.
俾把11號刀片。
There's a question from the audience. What is the blood pressure of the patient at the moment?
What's the blood pressure?
Because the surgical field is quite dry.
Mean around 60 systolic.
More important question, Shams, what's the pulse rate?
The pulse rate around 50.
Ah, you see, that's the pulse rate, it's the key.
Yes, but Sham has also done quite a good injection. He's had a pretty good preparation. The patient's position is a good position, and it's still not yet a fairly broad surgical field, so we don't expect too much bleeding just at this stage. But I think we need to adhere to the principle to make it as comfortable for ourselves as possible. So the best possible operating position, the best possible operative field translates into the best outcome for the patient.
Shame we see you operating down this telescope rather than off the screen.
I'm still not used to that method.
How's your neck?
Seems all right at the moment.
We'll ask again at the end of the operation. Just for a point of for those of you who are starting off on your sinus surgical careers, if you're going to be doing a lot of sinus surgery, you really should try and learn to operate off the television screen, because ergonomically you can end up doing significant damage to your cervical spine and getting significant problems in the long term. So just be aware that if you do a lot of phys, that it's probably better to learn to operate off the screen.
Cái個拍得下注火石有冇？濕㗎。再嚟得加下注火石。Prius. So it looks quite all right now. 個 chip 褪咗出嚟，往入啲。張床可以 rotate 過去嗰邊少少，嗰邊，係多啲唔得。OK 夠。直塞㗎，預備一個直嘅科石我。
Yes, there's a question from the floor. They would like to know what anesthetic techniques the anesthetist has been using for this patient, because the surgical field at the moment is actually quite good.
We are using the
And just now, Dr. Shah mentioned that the patient has a pulse rate of 50. Is a beta blocker being used for this patient?
No.
No beta blocker.
We use the focal and also the...
We can't hear. Can you maybe get closer to the mic?
夠光啲都啱光度，都啱。好，俾一粒你先。
Can our anesthetist friends maybe get closer to the mic, because just now we can't hear you. Can you hear us, Sham?
Yes, I can.
The question we have asked, but we cannot get the answer quite clearly yet, is whether we have used beta blocker in this patient.
The anesthetist. They are preparing the mic for the anesthetist.
So you think this is a fungal ball, Shane?
Yes, I think so.
What's the difference between a fungal ball and diffuse chronic fungal sinus disease?
We are not using the beta blocker. We are using the TIFA, the total intravenous anesthesia technique.
Yes, that's a very good technique, and you prevent the vasodilatation that you get with the inhalationals, and it certainly does help the surgical field if you can use total intravenous anesthesia. I just run through the difference between a fungal ball and chronic fungal sinus disease. A fungal ball is normally an isolated sinus. In other words, it's only one sinus involved. It's almost always unilateral, and it looks very much like what you can see here, which is thick, sort of granular tissue, which is quite firm and comes out in bits and pieces rather than the peanut butter, thick, gooey, sticky substances associated with chronic fungal sinus disease. So the good thing about a fungal ball is that the fungal ball is a very good prognosis for the patient. And once you remove the fungal ball, there's not a high tendency for occurrence of disease, and the patients normally do very well surgically. You can see how the fungal ball has widened the middle meatus there as well, because Sham's able to start removing a lot of that fungus, and he hasn't done an uncinectomy yet, so there's significant widening of the middle meatus by the fungal ball. So Sham, which technique for removal of the unsnit are you going to use?
The swing door, probably. I'm still using the 0-degree lens at the moment. So see if I can see the opening. No, I don't see the opening. So now I am going to take down this uncinate process. Freers, suction freers. We see the free border of the uncinate process here. This is the free border.
Sham, just palpate and see if we can see where the insertion of the unsnit is on the lateral nasal wall. See, if you were going to use the traditional technique, where would you make your incision?
Here.
There, okay.
You see, this is quite hard. So the main bulk is here, and the incision I will make will be somewhere there, along here. Here. Okay, backbiting process. Now I insert the backbiter.
This is the big backbiter. This is the traditional
right.
old big backbiter.
Get into the infundibulum. Take the first cut, second cut, rotate a little bit.
A good rotation there with the third cut. It's very important.
Okay. A curve probe. Suction. Luyện翻直塞卡俾我哋。
We have not heard from the anesthesiologist.
好，俾個 curve probe 嗰個90度嘅 probe，個 probe 係喺嗰度。So I try to elevate it medially， 俾個 through cutting 嘅45度 force， 細少少有冇？俾個 micro debrider 我哋。俾個 probe 我，再俾個 backbiter 我哋 backbiting force。
You see the unslit bone nicely there as it goes up towards the frontal recess.
Yeah. 直細鉗。直。俾個 micro debrider。
You see the unslit bone nicely there.
Yeah.
You've fractured it.
Yeah. Để個 probe 我哋。直細鉗。
Are you going to go into the frontal recess at all, or are you just going to
Probably it's free of disease from what I think. At the moment, I think the disease is basically limited to the maxillary sinus. all those we see in the anterior ethmoid is probably secondary changes. 好，比較直塞㗎。好，俾個 micro debrider。Okay, so we start seeing the bulla behind it. 直塞下。So this is the bulla. Now I will change over to a 30-degree lens. See if we can see the content of maxillary sinus. 30度，同我轉一轉。得，騰喺度得啦。睇個 orientation。OK。加光啲，係 curve sucker。係。俾個 backfighting force 入去。好，將床較 rotate 我呢邊少少，多啲。OK。curve sucker。
You can just see the beginning of the ostium there. If you change to a 45 or a 70, we'll be able to visualize the ostium.
45度鏡有冇 The opening is there.
Yes, we see it. Do you think it's slightly more laterally receded than the normal ostium?
That's right.
Because normally with the 0 degree, we should be able to see it at least, maybe just see it. 30 degree, most of the time we can see it.
45度，係。
Right from the beginning, you mentioned that there's a possibility that you may...
向右，係。
Sham?
Right.
Yeah, right from the beginning, you mentioned there's a possibility that you may need to go through the bimeatal approach or even the canine fossa approach to remove the material inside the sinus.
Right.
But let's say in this case, if it is clinically fungal sinusitis, do you think you need to remove every bit, even though you may need to go through a separate approach, or else you can just do a good mini-fest make sure the sinus draining well and see if the rest can be healed on its own. What's your view on that?
I would definitely remove all fungal material, if possible. I would not leave any behind. So I may have to adopt other approaches during the operation. Curve suction.
I think it's very important to remove all the fungal material from the sinus. If you leave fungal material behind, the chances of the fungus recurring are very, very good, and you will find that the disease returns within 3 or 4 weeks of the operation. So you really need to make sure that all the fungal material has been removed from the sinuses.
Well, the opening is there, but it's receded. It's quite lateral. Okay, so probably I would not enlarge this opening. I think the size is quite all right. The problem is the lateral situation. If I do too much manipulation around here, I will end up with scarring, fibrosis, and the result may not be good. So I would certainly adopt other approaches now and see if I can remove the rest of the fungal content inside the maxillary sinus, but leave this passage relatively intact.
Maybe for the camera control staff, can you move the external view to the right lower corner? Yeah, because that just blocked the lateral ostium just now. When you have two picture-in-picture superimposed on each other, maybe the external view should be over the right lower corner rather than the left.
Bigger TV forceps more. Bigger freest dissector. 係咪俾個 nasal speculum 先？個 nasal speculum。
Dr. Warmer, in his lecture, he mentioned about the position of the patient, that it is slightly...
Yep, he is still slightly head up.
Is that slightly head up around 20, 30 degrees?
I would say 15 degrees.
15 degrees.
And the neck extended a little bit.
Thank you.
Shift under okay. Freest elevator. So like a speculum. Our freest speculum. Trocar and cannula. Now I have entered the inferior meatus. You can see the nasolacrimal duct opening here. Do you see the nasolacrimal duct opening?
Not sure. Can you massage? Yeah, I can see the bubble now.
Yeah, okay.
Can you get the lacrimal sac gentle massage?
You see? Yes. You see the bubble?
Yeah, the bubble coming.
Okay, so I will try to avoid that. We will trocar and cannula over there.
Are you using a 30-degree angle or 70?
30.
Thank you.
Take suction. Okay, see if you can see anything inside. 攞咗個 sheet 出嚟。 Actually, we don't see much disease inside.
Yeah, just some blood.
直塞下
Shane, we got to look for that calcification that we saw on the CT scan. That make sure that it's not there. You've got to make sure you can visualize using the 70-degree scope through the trocar all the area of the maxillary sinus, so that you conclusively have evaluated the entire maxillary sinus.
Right. Okay. 俾個直塞㗎，我哋先。俾翻個粗吸人 cannula 我。俾個直塞下。俾翻個直粗吸人 cannula。俾我睇翻先。OK。Inside. Okay, I would like to enlarge this opening a little bit. Để cái thắt cái hạ suy vào xem này. Hậu. Hậu ạ,頭翻係 shift 落去先。orientation 轉咗少少先。好。OK。OK， 俾個塞下我哋。俾個食嘅 through cutting process 係。再嚟啊！好。大嘅咧。俾個塞架我先 ，curve 塞架，好，俾個塔架書科石。俾個 backbiting force。 去唔到，俾個 curve 塞下我哋。Okay, I will try to examine it by a 70 degree.
It looks like just very edematous mucosa.
Yeah. Đây rồi xem. Đó, cầm nhớ. Thôi rồi. Đây cái anti-fog ở đây. Để đừng suction.
Dr. Sam,
Right?
why don't you make the puncture from canine fossa for better visualization?
Yes, I will. But before I do that, I'd like to have a better view here. See if I can get another view. This is the maxillary sinus mucosa.
You're looking at the roof.
Now, I'm looking at the roof and the anterior limit.
Yes.
It's free. Here is the anterior limit. This is the lateral wall. Now I'm turning inferior. So this is the inferior aspect. It's not a very big maxillary sinus. It looks quite all right. Okay. So I would like now try to do a canine fossa sinoscopy. See if we have further additional information.
But when you do that, what area that you think you haven't seen with the
I think I have seen all the content already.
So why do you need to do the canine fossa in that case?
Just to be safe, in case I miss something.
Let's have a look at the CT scans again for the audience if we can.
Okay. Can I have a pointer? So now I think we have removed the main bulk of the fungal sinus disease here. The maxillary sinus is not as big as the opposite side, as you can see here. You have a very good pneumatized maxillary sinus, but on the other side, there's a lot of sclerotic bone here. Actually, the volume of the sinus is just like that. Just what we see in through the inferior meatal antrostomy is as big as that. So this is the
significant thickening of the floor of the orbit. You see the floor?
Yeah, here. Yeah.
A lot of new bone formation. A lot of new bone formation.
Yeah. I think the classification that you just talked about are actually the fungal content, rather than a classification along the the wall of the maxillary sinus. So actually it's not a very big sinus, as you can see here, as you compare with the other side. So we have, through the medial meatal approach, we have reached here already. So by suctioning, I suction all the content out. Now this is the actual size of the maxillary sinus.
Shane, when you look at those CT scans, it looks like there's been a large opening created by that fungal contents into that maxillary sinus.
Right, that's right. But actually, the passage itself is not that big. I mean, we see a huge depression or cavity here. But the connection with the maxillary sinus is actually not that big. What do you think?
Yeah, let's go back and look with the 70-degree scope in the middle meatus again and identify the natural ostium. And,
okay.
And if you've got a nice right angle curved sucker, if you can even instrument that natural ostium of that maxillary sinus, and that's the way. Have you got a malleable sucker there? One that you can bend?
Yeah, malleable sucker. Malleable sucker.
If you've got one, I don't know if you have one. If you've got one, if you can bend it fairly acutely so that you can get into that maxillary sinus and under vision.
Okay.
You see that sucker is not a malleable sucker, the one you've got there. That's an ordinary one. Let's have the endoscopic view, please.
Endoscopic view.
We've got it. So what's that you're taking out there now? What's that?
A loose piece of bone.
Yeah,
probably
that might have been the calcification that was in that maxillary.
Probably not. It's the piece of bone I introduced into the sinus during inferior meatal antrostomy.
Oh, okay.
Now I can see a bigger opening through here now.
Can you slide that sucker into that maxillary sinus, bro?
Right angle sucker. See if I can get a clearer picture. Three years. Curved sucker. Now this is the opening.
Yeah, okay.
Nothing inside from this point of view.
Okay, that's good. We got better visualization now.
Yeah.
Okay.
So the next question is whether we still need to confirm it with the canine fossa approach.
Now, I think if you've seen the maxillary sinus contents with the inferior meatal approach and you've got a good visualization of the natural ostium, I would think that it would be superfluous to do a canine fossa approach.
Okay. So a final look at the inferior meatus.
Shame, you see that little bit of a bone which
Yes,
has been
yes.
pushed in.
Push in.
Can you take the double right angle ball probe and just pull it out so it'll
Yeah,
give us a better
I
visualization?
see if I can pull it out.
Yeah. That'll give us a better visualization of the maxillary sinus.
Okay. My ball probe.
So for the audience, what we're talking about is this bit of bone here, which has been pushed in. So I'm just going to get Sham to slide the ball probe underneath it and pull that out. That's one of the problems with the inferior meatal approach, is that the inferior meatus is a very thin, large area bone and fractures quite easily. And you can see that it makes that maxillary sinus look a lot smaller if the bony fragments are pushed in towards the maxillary sinus. While you can see now the maxillary sinus is looking a lot larger than it looked like before we pulled these bony fragments out. Because I personally prefer to do the anterior canine fossa approach, because you don't get these bony fragments pushed in to the same extent as you do through the inferior meatus.
Okay. Okay, it's out. Good. Now can get a better view. Polypoid mucosa.
Yes.
This is the roof.
Yeah.
Lateral wall. Inferior wall. Postero-inferior recess.
So
Down there.
It all looks very clear except for the edema.
Yeah, this is the most posterior limit of the maxillary sinus. This is the floor. Okay, any further question about this patient?
Any question from the floor?
俾返零度我哋。
Sham, normally, if you haven't done it, will you choose the canine fossa approach or use the inferior meatal approach for the sinoscopy?
Normally, I would use the inferior meatal because a lot of patients after canine fossa approach complain about paresthesia of the cheek and some swelling postoperatively. So I would prefer inferior meatal approach.
Let's have the surgical overview rather than the endoscopic picture. Shane, we're just going to get a good look at you before you finish up.
Right.
We've done a study to see what the incidence of lip anesthesia and teeth anesthesia is with the canine fossa approach.
Right.
Because we use it we use it a lot.
Right.
And the incidence of anesthesia in the post-operative period is 30%.
30%.
So it's very high.
Wow.
So we warn our patients about that.
Right.
But the interesting thing about that anesthesia is that it's in all of our patients it's resolved.
Right.
Within 3 to 6 months. It can take up to 6 months for that anesthesia to resolve.
Right.
But in all cases it has resolved.
Right.
So that if you warn the patient that they might have either numb lip or numb teeth,
right,
then there is a good chance that it will resolve in a 3 to 6 month period afterwards.
Right.
But that is a very nicely done operation, and good thanks to the anaesthetic and the staff that helped you there, Shane. Well done.
Thank you very much. Thank you.
Is there any other question? There's another question, Sham.
Right.
Dr. Sam, I would like to ask you a question.
Right.
If we just enlarge the natural stem and remove all the fungal material,
right,
would you think it would be better than meta-inferior antrostomy?
Right. Now, if the fontanelle are membranous, and you think you can enlarge it without traumatizing too much the passage or the tunnel, then I would normally enlarge and make it a middle meatal opening, make it very big. But in this particular case, as you see, the tunnel that is seen on the patient actually is not that wide. If I do too much manipulation, I really worry about postoperative stenosis. So instead of doing that, I would prefer using another route to check the maxillary sinus, or even remove the remnants of the fungal ball through the inferior meatus, rather than to struggle with a very difficult middle meatal INA.
Any other question? Yes.
How do you manage the patient post-operatively? Do you give systemic antifungal agents?
Well, for fungal ball, it's quite inert. It's not invasive fungal sinusitis. Normally, we don't give patient any antifungal agent, but I would certainly cover this patient with a week of antibiotics, usually Unicin, and check him post-operatively. Sometimes we do see patients with recurrent balls. They may not be obvious. Maybe a year later, when you check the sinus, you will see some fungal collection at the floor. May not be too much. Then we may have to do additional lavages for the patient. I think we need to follow this patient up, but normally no antifungal agents.
Do you give topical or systemic steroids post-op also?
No. Usually we don't give any topical agents. We find that the post-op result of these single balls are very good, and they have a cure rate of over 90%, and usually no medication required.
I think in the interest of time, I think we should move on to the next bit of our program today, which is thank you, Dr. Sham, and maybe thank you to all the theatre staff.
Thank you.